I'm very happy to be back in the I'm very happy to be back in the discussion seat with Sharmin. We are going to get right into it today. It is a 30-minute VMR that cannot be 31 minutes today due to some of our time constraints. But Maddie has an amazing case for us, and so we will go ahead and jump right in and get going here. Thanks again for joining us.
All right. Okay. Hey everyone. So I'm going to be presenting the case. So I will jump right in. So the chief concern is knee and ankle pain. In terms of the a bit of the HPI, so this is a 32-year-old male who presented to the ED because of acute onset left knee and ankle pain and swelling. So a little bit of the story. So about 2 weeks prior to presentation, he said that he started having some burning when he urinated and some purulent urethral discharge. And then that was 2 weeks prior to presentation. And then 4 days prior to presentation, he developed left ankle and knee pain. The left ankle pain was really intolerable when he went to work. At his work, he stands a lot, so it was really making it hard for him to stand. And the pain in the left knee and the ankle slowly progressed over the next few days. As I mentioned, there was swelling in it too, and it was really making it hard for him to stand at work. So that's why he came to the emergency department.
All right, what a start. I'll start and then pass the mic to the amazing Dr. Jack Penner for his thoughts. So we have I think what it sounds like otherwise healthy man who's coming in with acute onset of left knee and ankles swelling and pain. So whenever I'm thinking about joints, I feel like, using the right semantic modifiers is helpful. So, we think about like, how many joints are involved. This is two joints, it's on the same sides, and kind of whether this is like arthralgia or arthritis, it kind of sounds like, oligoarthritis that is involved on the same side. So again, whenever we think about like single joints, we often think of like septic arthritis, gout, inflammatory as two joints. Although inflammatory and septic still on the differential, that broadens the possibilities. What I would say, like, again, no misdiagnosis here, it remains an infective source. And especially if it was on different sides, again, it would be odd unless like it's a disseminated infection, but you can think about like a skin and soft tissue infection that is extending. So an exam would be really helpful. The other thing with the prior history of, urethral symptoms in a young man, the one thing that you don't want to miss is like a gonococcal infection that leads to reactive arthritis, especially like given the time course of like having the urethral symptoms and then later on developing that. To know if there's any other rash, any systemic signs would be really helpful. So infection, it's where I would start. And then, there's a whole slew of, in younger folks like psoriatic arthritis, like autoimmune diseases that for me would be kind of the second pass. Jack, what are you thinking?
I'm with you 100%. I think, even though there are two joints involved, I'm still using that monoarticular arthritis framework of septic, crystalline disease, and then also autoimmune mediated causes. Septic, all the ones that you mentioned. In somebody young, the most common pathogen is gonococcal, is a gonococcal infection, and then somebody older, the most common pathogen is going to be Staph aureus. And as you mentioned, we already have some signal for the possibility of gonococcal septic arthritis. Crystal disease is rendered less likely, but not impossible, given that this is a 32-year-old person. We can see some cases of gout or pseudo gout in a younger individual. And while we characteristically think about crystalline diseases as monoarticular, you can definitely have it move from one joint to another joint. So the big toe progresses to the ankle progresses to the knee. And one important thing to know is that when you move from monoarticular gout to polyarticular gout, the systemic inflammatory signature of that disease ratchets up dramatically. So people with gout in the knee and the ankle, you may see fevers associated with it and a much more robust inflammatory response just because there's more joints that are inflamed. That inflammation can spill spillover into the systemic system. The autoimmune causes you mentioned, Sharmin, are interesting here because it's another place that sexually transmitted infections rear their ugly head. The two autoimmune diseases that can cause a mono or a monoarticular or sort of two joints are going to be the two RAs, right? Rheumatoid arthritis can have monoarticular flares, and then reactive arthritis, usually after a GI or a GU infection, is going to be, I think, another one that we're thinking about. And the GU infections that can do it are usually chlamydia, which can sometimes be the silent companion with gonococcal urethritis here. So the discharge that we're seeing is favoring a gonococcal infection, but sometimes chlamydia can come with that and lead to a reactive arthritis. Your point about the time course, I think, is super important because usually reactive arthritis happens weeks after the initial infection, whether it's a couple weeks after a diarrheal illness, say with Campylobacter, or a couple weeks after a chlamydial GU infection. However, that's the average. Some people develop a reactive arthritis within days of the initial infection, and some people maybe several weeks to a month later. So this time course would be atypical, but not incompatible with reactive arthritis. But again, I think we're going to put all of our cognitive efforts towards excluding a disseminated infection of gonorrhea. And once we exclude that, we may say, okay, this is actually a post-infectious complication rather than an intra-infectious complication of gonorrheal infection. All right, Maddie, take us forward.
All right, brilliant discussion. So in terms of review of systems, no other joints besides the left ankle and the knee are swollen or painful. He did not report any low back pain, no changes in his vision, no red or itchy eyes, no fevers, chills, night sweats, difficulty breathing, chest pain, no skin changes or oral lesions that he noticed. In terms of his past medical history, he did say that he had a history of gonococcal urethritis about 3 years ago, which was treated. And then when we asked about any injury to other joints, he mentioned that about 15 years ago, he had a traumatic injury to the left knee. He dislocated it when he was playing basketball. There was never a fracture, but he wore a brace for many months at that time. And kind of since this was like 15 years ago, he's kind of has chronic intermittent flares of knee soreness that self-resolve of that left knee. The ankle pain itself had never occurred before. No, he does not take any daily medications. The family history is unremarkable. The social history, he works in a restaurant in California as a chef. He does long shifts where he is on his feet standing up. Does not use any alcohol or drugs consistently. He's in the past 6 months, he's been sexually active with 3 different female partners. He does not use protection. And in terms of the vitals and physical exam, I actually have some photos that I can show you. But for vitals, he was afebrile and all of the vitals were within normal range. He was hemodynamically stable. In general, he appeared, in discomfort, but no acute distress. For HEENT, he had a clear oropharynx, no mucosal lesions, no lymphadenopathy. The heart and lung exams were normal, no murmurs, lungs were clear. Abdominal exam was soft and non-tender. On the GU exam, there was some purulent urethral discharge. And then for the extremities, there was, and I'll show you some photos, there was both left ankle and left knee swelling and redness. Both were warm to touch, and he had some pain with passive movement of both the left ankle and the left knee. He did not have any back pain and no other joint pains. All the other joints were he was able to move it without any issues. And no abnormalities on neuro exam. And then let me show you. So actually these photos were not, basically when I was taking the history, I kind of asked if he kind of had taken photos of the joints when he started noticing it. So these are photos on his phone that I took a photo of. If that makes sense. From when they started. Can you see this? Okay, so these are, photos, as I mentioned, from his phone that he had taken at home before he came in. And you can see the left knee swelling here. And then this was the left ankle swelling. And that I would say that they looked about the same when I saw him in the hospital. Okay. And maybe I'll stop there.
All right. So super, super interesting unfolding here. I think maybe I'll touch on the background medical history and then leave the exam and everything to you, Sharmeen. I think, if we look through the past medical history and say, what are the things that move the needle here in terms of prioritizing certain diagnoses? I think the two things that are moving the needle the most are the sexual activity. And then interestingly, also, at least for me, his history of a prior injury in that knee. And I think what all of those things do is they increase the probability of an infection that has disseminated to the joints. If we think about the sort of two variables that we need for infections to disseminate to certain areas, usually we need an underlying reason to acquire that infection, and then we need some sort of compelling reason for the infection to set up shop there, right? Some reasons that the infection can set up shop in a certain area is because that area gets a lot of blood flow, right? So we can think about, for example, individuals who have endocarditis. They may have a particular predilection for developing septic emboli or abscesses in visceral organs that get lots and lots and lots of flow. For example, the kidneys or the spleen, right? Those are primarily organs that filter all of our blood. And so we can sometimes see things set up shop there. In the case of musculoskeletal, or in the case of infections that set up shop in joint spaces, oftentimes pre-existing damage to that joint is a big risk factor for infections to settle there. So the fact that he's had a prior injury to that left knee makes me wonder, oh, is that potentially an environment where there's abnormal osteoarticular surfaces or other prior existing damage that may make it more likely for bacteria to settle there? And then if we think about what's the portal of entry, we certainly see that this is somebody who has had gonococcal infection before and has recent activity that may increase the risk for this. And so I think, right, if we were saying, well, gosh, could this be a primary septic arthritis versus a reactive arthritis in the first aliquot? Maybe septic arthritis is starting to run ahead in that race just by virtue of the prior episodes of gonococcal infection and the fact that we know that this is a pre-existing structurally abnormal joint. The question about the ankle, I think, is sort of left open at this point. I will say that disseminated gonococcal infection has a predilection for the distal joint, so or elbows, wrists, knees, and ankles tends to set up shop there. But I think, again, all of these things are really probabilistic judgments, because I think the jury is still open for all of those three categories, right? But we may be putting a few more pennies in the septic arthritis hat as a result of some of these features. But yeah, I'm curious, Sharmin, what do you make of the exam and some of the other stuff that we have here?
Yeah, beautifully discussed. So kind of like starting with the vitals, right? When I'm evaluating a patient like this, I'm like, okay, where can I find other signs of systemic infection or inflammation? And he's afebrile, nothing on the vital signs to point to that in his exam. Thank you for such a thorough exam. Because it's really helpful, right? We don't see any rashes. I think a good cardiac exam, listening for murmurs here is important. And as mentioned, if you're invoking like two joints that are that the link between them are disseminated infection, then we want to look for like any evidence of endocarditis, back tenderness, any other foci that would make you think this is a bacteremia is a link between all of them, which we don't see here. I think the purulent discharge is something to be swabbed and sent to labs. And in terms of like the ankles itself, I agree with you. Kind of the tension here is like septic arthritis versus reactive arthritis. And, oftentimes with reactive arthritis tends to be a little less inflammatory than septic arthritis. So this is a need that should be tapped. So sending for arthrocentesis, oftentimes with reactive arthritis, you have white counts, but are not at higher degrees. The culture is going to be negative. Blood cultures is another thing that I would send out on this patient, and in addition to kind of workup. The other thing that I would consider is just kind of HIV test in this patient if he hasn't had any. He's had a prior history of STIs, his sexual activity, again, just to make sure that we're not dealing with the immunocompromised host. In terms of like, is there anything else, reactive arthritis can have Skin manifestation, mucocutaneous manifestations, again, they're not very common. Oftentimes, I think it's just a joint, but any other thing would uh, maybe point you towards a reactive arthritis a little bit more that we don't have here. So, yeah, I agree with you, Jack. I hold that tension as well. And then we'll see what Maddie has in store for us.
Yeah, the only thing that I will share that I forgot to mention is mistake that I have made many a times that I hope no one here makes as many times as I have is in addition to the usual stuff that we send for this, and Charmaine, if you mentioned this, cut me off because I got distracted down here too. But I have forgotten to send the explicit gonorrhea DNA test from the synovial fluid so many times. Think, oh, it will grow on culture, but it's quite difficult to culture Neisseria gonorrhea. But we have very good DNA testing of it, and so the same nucleic acid amplification that we can use from the urethral sites or from cervical sites or rectal or pharyngeal sites, we can use from the synovial fluid too, which can be an important way to potentially clinch the diagnosis because it very seldom grows on culture the way things like Staph aureus does or other strep species does. So I have begged the lab to add it on many times, so hopefully you all do not have to as well.
All right, loving the discussion. So to jump into some labs, so the CBC, the white count was 10.9. Hemoglobin and platelets were normal. The metabolic panel was also normal. A CRP was 106. And as you both mentioned, so when arthrocentesis was performed, that showed 21,000 white blood cells. That were 85% neutrophils. There were no crystals, and the gram stain and the culture was negative. I'll give you some other labs that kind of came back over time. So an HIV was negative, an RPR was negative, and then for urine, the urine chlamydia test returned positive. The urine gonorrhea test was negative. And then the blood cultures were also negative. And then a chlamydia and gonorrhea throat and rectal swabs were done, but there was an issue with the labeling and the test, so we actually never got those results. And I guess I will also say that some imaging of the ankle and the knee were done that did not show signs of osteomyelitis. I'll pause there.
All right. So starting with, the white count, it's a little bit elevated. A white count, again, makes sense in the setting of an infection. And in terms of like the arthrocentesis, definitely those white counts, neutrophilic predominance makes us more concerned for an infectious process. I think with reactive arthritis, you can still get these type of numbers. Did they send a gonorrhea testing from the synovial fluid? Sorry if I didn't catch that.
Yeah, I don't think I explicitly said that, but it was negative.
It was negative. Okay. Oh, wonderful. And with the swab that is positive, this definitely should get treated with both gonorrhea and chlamydia. And I currently have a higher suspicion for this being a reactive arthritis than being a septic joint. So that's what I would treat the underlying gonorrhea and chlamydia infection in addition to supportive therapy. With a knee that has been dislocated in the past, but there's no, I think there hasn't been instrumentation of that knee because it doesn't sound like it has a prosthesis there. So because when you have a prosthetic joint, then your even a bit of a white count should make you nervous for a septic joint. However, in the absence of prosthetic joints, I do favor reactive arthritis in this case. Jack, what do you think?
I'm totally with you, Sharmin. I think this is such a fun exercise in looking at the strengths of the various diagnostic tests that we have, because I think this is a problem space that we contend with all the time, particularly in an acute inflammatory arthritis. There is so much overlap between so many of the tests that we send between those three, right? Crystalline disease can look like septic arthritis. Septic arthritis can look like an inflammatory arthritis. Crystalline disease and inflammatory arthritis can look alike. And so really, right, we get into sort of the heart of the reasoning process here, which is ultimately making an argument, right? Every time we try to establish a diagnosis or a management plan, it's just as much a process of thinking through the case as it is making a sound and logical argument to support whatever conclusion we come to here. And I think if we look at this case overall, we can make a much stronger argument for this being reactive arthritis than we can for this being acute gonococcal arthritis. Because if we ask ourselves, well, what are the pieces of data we need to establish a diagnosis of disseminated gonococcal infection or gonococcal arthritis? Ultimately, you need a compatible syndrome, which we do have, right? We have an acute inflammatory oligoarthritis, but we also need evidence of gonococcal infection from some site somewhere in the body. So that could be the synovial fluid, the blood, the skin, or mucosal surfaces, right? And from the synovial fluid, cultures are only positive about 50% of the time in cases. So a negative culture from the synovial fluid is still compatible with the diagnosis. But as we get accumulatingly more and more evidence to say, okay, well, there's nothing on the mucosal surfaces, there's nothing on the skin, and there's even no DNA of gonorrhea from the acutely inflammatory joint, the strength of that argument starts to weaken. But the strength of the counter argument that you said of reactive arthritis gets stronger and stronger, right? We have a synovial fluid count that is compatible with reactive arthritis. Counts can be anywhere from 20,000 to maybe 60 or 70,000. So this is right slam dunk in the middle here. Whereas gonococcal infections can be low in the 20s, but they tend to be higher maybe in the 60 to 70 range. So again, the synovial cell count is compatible with both, right? But again, the evidence of gonorrhea somewhere in the body just isn't there for us. But then if we go back to the reactive arthritis hypothesis, right, we have chlamydia in the genitourinary tract, which is an organism that commonly leads to the development of reactive arthritis. We have a compatible synovial fluid count, and we have a compatible timeline of disease, right? A couple weeks after an initial onset of symptoms, we're seeing a couple of joints get picked off. And the most important thing is Maddie and the team did a great job of excluding the alternative causes of an inflammatory arthritis, right? We don't see any evidence of crystalline disease, and we don't see any evidence of another pyogenic bacterial organism in the body elsewhere. So if we say, okay, well, can we make the argument for reactive arthritis, right? You made a phenomenal argument for it here, and I think we can say comfortably that most likely it seems like reactive arthritis, right? We'll treat the GU infection and then treat the joints and see how things go. We may see that in a week, oh no, the elbow is now flaring up and there's another wrist, and we may have to revisit that working diagnosis, but that still, I think, would all fit with a reactive arthritis because we can see other joints pick up along the way. So ultimately, right, like again, I love this case because it really tests our argumentation skills and our ability to sort of make a rhetorical argument here. And I think all of the data is there to ultimately come to that conclusion.
That tension you described, it's so real. Like, let's say if that count was 60K, 50K, and cultures take a while to grow, right? So would you, in the meantime, treat for septic arthritis? Is it reactive arthritis? So that tension is very, very real.
I think I would probably like if we were waiting for this stuff to come back, I think I probably would have kept him on ceftriaxone in the interval time until the cultures came back. What about you?
Oh, 100%. I agree. Because again, if you think about it, the thing that you don't want to miss, the thing that would have the most consequences for this patient would be a septic joint. The question is like, oh, whether ortho would go and debride the joint. I think that is something that you again will ask if the white count was higher, the gonococcal DNA wasn't back, the cultures were cooking, and the white count, but the only thing you have is a white count. I agree. I would like keep him on. And then just have ortho evaluate the patient, but less likely that he would need debridement, just close monitoring. But yeah, that tension is very real in real life until the cultures are finalized.
Yeah, brilliant discussion. And we were the same tension the team was talking about as well. And just to kind of answer that question, prior to the cultures he was on, empiric ceftriaxone and vancomycin, and then doxycycline was added when the chlamydia returned positive. So yeah, just to kind of wrap up how the team was thinking about it, ultimately, because of the confirmed chlamydia infection, as I mentioned, he was started with doxycycline. And the most likely diagnosis that the team was thinking of was exactly as you mentioned, this like reactive arthritis, kind of post-chlamydia reactive arthritis. The team was also considering, especially given the history, disseminated gonococcal infection. And I skipped over this a little bit, but when of the imaging of the left knee in particular, there were some signal changes in the patella. So that kind of made us really consider if this was disseminated gonococcal infection, but we actually went down to radiology, and talked with them, and given kind of the history of the traumatic injury of the left knee and the rest of the clinical picture, that was thought to be less likely. And as I mentioned, all of the gonorrhea testing was negative. So ultimately, I think the working diagnosis here was reactive arthritis from chlamydia. And he was treated with doxycycline. He also finished the ceftriaxone. And when I checked his chart, he had a follow-up visit, and the swelling and the pain had resolved with that. So amazing discussion. And I really loved your point about, I think, Jack, you made it about kind of the at-risk joints and how, who knows, but potentially this traumatic injury that he had of the left knee many years ago just made that joint kind of at risk for this. But great, amazing discussion.
Right on. What a great case. I know that we are tight on time, so I just want to say, Maddie, thank you for presenting. Sharmiz, as always, a brilliant, brilliant discussion. And Anmalpreet, we'll turn it over to you to bring us home with the teaching points.
Amazing case, an amazing discussion. Thank you so much. So I'm sharing what I learned from the case. Basically, from the start, we were just thinking about if it is septic arthritis or it is reactive arthritis. So we had a patient with knee pain and ankle pain, which classifies as oligoarthritis, and acute joint pain in young patient makes us think about something like septic arthritis. But sometimes the involvement of more than one joint makes it less likely. So we take out our differentials of joint pain, which is septic, crystalline, and autoimmune. So in septic, if we see this is a young patient, we suspect a gonococcal infection. And in older patients, we suspect Staph aureus to be the culprit. In crystalline, we have, again, gout and pseudogout, which is rare, but definitely possible in young people. And if crystalline is the case, and we move from monoarticular to polyarticular in these cases, systemic inflammation increases immensely if it is a crystalline in this case. And third, we have autoimmune, which we have rheumatoid arthritis and reactive arthritis. Reactive arthritis, which is either after a GI infection or a GU infection, and in which the chlamydia is most likely the possibility in the GU infection. So basically, what is reactive arthritis? It is just another name of Reiter syndrome, and it is characterized by a triad in which we have urethritis, conjunctivitis, and arthritis. So here we had that urethritis, the purulent discharge. So in this case, time course is very important because the Reiter syndrome, it happens weeks after infection mostly, but can happen after some days too, as clinical presentation varies from person to person. Then we had, in this patient, we saw a past medical history of gonococcal urethritis and traumatic injury to the knee, which indicates that probably there could be a disseminated infection. And Dr. Jack told us that a trauma increases the risk of infection, just like damaged walls in case of infective endocarditis. Some organisms attack the damaged walls, especially in cases of infective endocarditis. That way only the joint that got trauma can be attacked by certain organisms. And also, infective endocarditis can embolize as well. So we need to look for other symptoms of emboli in this case, if it were that. And we also need to look out for the HIV status, blood culture. And most of the times, blood culture does not show gonorrhea, So we have to go for gonorrhea DNA status from the synovial fluid, as the joints are inflamed from that only. And as Dr. Sharmin told us, that prosthetic joint increases the risk of septic infection. So if it were prosthetic joint in this case, then we would again suspect septic arthritis in this case. So we were actually juggling between septic or this reactive. And then, we saw that gonococcal was negative in cultures, and in DNA was negative. It had acute inflammatory oligoarthritis, but we need an evidence of gonococcal infection from some site to classify it as disseminated gonococcal infection. So it had chlamydia positive, so it was going towards reactive arthritis only. And so then at the last, we said that we need to follow up the patient as there is a possibility of other joints involvement. And so while we wait for the diagnosis, we have to start this patient on ceftriaxone, because if it were septic arthritis, then the consequences would not be good if we don't treat this patient. And for chlamydia, we need to treat with doxycycline. Ultimately, it got diagnosed as reactive arthritis. And yes, that's pretty much it from my side.
Woo! Preet, thank you so much for some phenomenal teaching points there. Those were absolutely brilliant. A big thank you to Cachal and Gerardo for scribing for this case. And one more final thank you to you, Sharmise. Thanks for the discussion. I hope everyone has a wonderful rest of the day. We'll see you next time. Take care, y'all.
Thanks all. Bye.